Okay, before starting the assessment, I will wash my hands and put on a pair of gloves. So good afternoon, my name's Julia Tihuia and I'm from AUT. What's your name?
Stephen Charles Tihuia.
What's your date of birth?
2nd of the 2nd, 1971.
Terrific, thank you. Today I'm going to be doing a cardiovascular assessment on you. It might involve some touching, palpating, and at times listening to your chest, and it may be uncomfortable at times. If you're uncomfortable at any time, can you please let me know?
Yep, sure.
Thank you. That's great. Okay, are you in any pain before we begin?
No pain at all.
Okay, that's good. So it's important to note if the patient was in pain, we would go down the questionnaire down OPQRST mnemonic, and we'd also do a pain scale from 0 to 10, 0 being not much pain at all, and 10 being the worst pain ever. Okay, we'd also get a 3 lead and a 12 lead early on, and we'd decide on treatment and status early on. So for example, if the patient was having central crushing chest pain and it was indicative of being cardiac, we would give an aspirin. So what aspirin does, it stops the platelets sticking, preventing a clot. Or the patient, we could give them glycerol trinitrate if there was no contraindications and the drug check was all good and he was not allergic to it. What glycerol trinitrate does, GTN, that reduces preload and afterload in the heart, so it reduces the amount of blood coming into the right side of the heart, making less work on the heart, and it also dilates all the veins and arteries, and particularly the coronary artery to the myocardium, so giving more oxygenated blood to the heart muscle. So that would make them feel better. Okay. So looking at the patient, I'm going to have a look at the surroundings, looking around the room. I note that the room is nice and tidy. There's no signs of medications like GTN or aspirin or any cardiac medicine sitting by the bed. Okay. Looking at the patient, he's comfortable at rest, he has a patent airway, he's not short of breath, he's not sitting in a tripod position, he's not using accessory muscles. When he spoke to me, he was able to speak a full sentence, so somebody really short of breath that can only speak 1 to 2 words per breath, they become a status 1 patient. Okay. Note also that I cannot hear any stridor or wheezes or any abnormal noises. Note that the patient can also have a cardiac wheeze, it's not just an asthma wheeze. Okay, quite often patients are short of breath, sit in the tripod position, lean forward, it helps in breathing. Okay, if the patient was short of breath, then I would need to intervene early on. He may need some oxygen, he may need some other medication. Okay, I cannot see any rashes on the patient. Actually, if I could get Stephen, could you please lift up your shirt just so I could have a general inspection of you from here? Okay, just up a little bit more. Okay, so looking at the patient, I can't see any scars, any obvious deformities. Patient is, good colour. I can't see any pulsating masses in his abdomen that would be indicated of a AAA. That wouldn't be very good. He's not diaphoretic, he's not flushing. Flushing would be indicative of mitral stenosis. He has none of that. There's no pedal edema, which would be indicative of right-sided heart failure. He doesn't have any, I can't see any distended neck veins, also indicative of right-sided heart failure. His abdomen isn't distended, same thing. Okay, looking at the patient, there's no missing limbs. So quite often diabetic patients may have had their limbs cut off, so has it got poor circulation. Can't see any sign of any drug or alcohol abuse. Can't see any medical alarms or medical alert bracelets on the patient. Okay, so that's really good. Notice that the patient's bed, he just uses 2 pillows at night time. If he was in a hospital bed or lots of pillows, that could be indicative that he lives with congestive heart failure. Doesn't appear that he lives with this. Okay, so I need to now inspect you, Stephen. So, starting over here, I'll get you to hold my hands, please. Okay, so while I'm holding your hands, I'm noting that your skin's nice and warm and dry. That's really good. Okay, I'm just going to feel the pulse in both your hands. Okay, nice strong regular pulse, they're both the same on both sides. So if the patient had a weak radial pulse, that could be indicative of a low blood pressure or something going on. We would then check the brachial pulse and the carotid pulse up here. Okay, so for the purposes of today we will check that. Okay, that's good. Okay, that's good. Check the other side. Check this side. Okay, that's terrific. Thanks, Stephen. Okay, I'll just go and get my stethoscope. Okay, gonna have a look at your hands before I have on any further. So looking at your hands, turn them over. So there's no brown reddish stains on the hands on either side. That could be indicative of bacterial endocarditis. There's no tarring or anything on the fingernails, indicative that he's a smoker. Okay, there's no clubbing of the fingers, so quite often congenital heart defects like tetralogy some of the people have a missing chromosome that can cause clubbing of the fingers. He does not have that. Okay, so he hasn't had any heart history since birth. Okay, so next I need to have a look at your neck. Okay, so the jugular vein is not raised. If that was raised up to 4 centimetres even, that could be indicative of right-sided heart failure. Looking at the other side. Okay, that's not raised either, so that's really good. Patient's really nice and warm and dry. It's not diaphoretic. Okay, so I then need to have a listen to your chest. Would that be okay, Steve?
Yeah, fine.
Okay. Oh, actually, before we carry on to do that part, just have a look at the whites of your eyes. Okay, so the eyes are really nice and white. There's no indications that he's anemic. Okay, so if they were a different colour, that could be anemia. If they had any yellow in it, that could be a sign of liver failure. Just have a look at your tongue. That's good. No inflammation. Poke your tongue out the other way. It's nice and hydrated and good dental hygiene. Excuse me. Okay, so having a look at, listen to your chest. Okay, this might be a little bit cold on your chest, Stephen. I'm just going to use this part of the stethoscope to listen to the top. Breathe in. Out. Breathe in. Out. Okay, so using this side of the stethoscope, I'm just going to have a good listen to Stephen's chest, because if there was any crackles down the bottom here, that could be indicative of left-sided heart failure. If there was crackles on one side, that could be indicated of pneumonia. If there was wheezes, that could be asthma or a cardiac wheeze. So just going to have a listen. So take a big breath in. Good. Out. In. Out. Listen to the other side. In. Out. Big breath in. That's good. Listening to the lower lobes now. In. Out. In. Out. So we listen down the middle. That's good. In. Out. In. Out. In. Out. One more. In. And out. That's really good. Stephen's got a nice clear chest. No wheezes. No crackles or any other abnormal noises. Just going to have a feel of your chest, Stephen. So I'm just feeling for any deformities or crepitus, lumps or bumps. Any lumps up here sometimes could indicate that the patient has a pacemaker. Could indicate tumours, broken ribs, that sort of thing. Just having a feel of your chest. You can't feel anything abnormal. That's really good, thanks Stephen. Okay, so now I just would like to have a listen to your heart sounds. Okay, so what I'm listening for is coming down to the second intercostal space. Okay, so this will be on the right hand side from the sternal edge here. That would be the aortic valve. So listening over here on the left hand side from the sternal edge at the second intercostal space there, that would be the pulmonary valve. Okay, so then coming down 5 spaces from the sternal edge, 3, 4, 5, this would be the tricuspid valve. 5 spaces midclavicular, 1, 2, 3, 4, 5. So I'm listening for the aortic valve, I think. Okay. Sorry. 5th intercostal space, I'm listening for the mitral valve. So that's from the midclavicular up here. 2, 3, 4, 5. So that's going to be the mitral valve. So having a listen now, I'm listening for that I hear the first heart sound and the second heart sound. Okay, 1, 2. Okay, breathe in. Yeah, just breathe normally. Okay, that's good. First and second heart sounds. So listening for the pulmonary valve. That's good. Hearing the first and second heart sounds. Okay. 3, 5. At the apex here, I'm now listening for the tricuspid valve. First and second heart sounds, can't hear any murmurs. Okay, so the 5th space midclavicular there, I'm now listening for the mitral valve. That's great, thanks Stephen. So I heard all the first and second heart sounds and I didn't hear any murmurs or anything odd. Okay, so Stephen, could I just get you to lean forward please? I'm just going to have a listen to your back now. So having a feel of the back, you can't feel any lumps, bumps or crepitus or anything like that. Okay, I'm just going to have a listen for any abnormal sounds. Big breath in, out, in, out, in, out, in, out. Take a big breath in and out. Over this side, in, out, in. Listening to the lower lobes now, and out, in, out, in, out, in, out. That's fabulous. I can't hear any abnormal lung sounds there. Okay, let's pop that down. Okay, so in summary, the patient is comfortable at rest, doesn't appear to be in any pain or discomfort, is well perfused, he has a good colour, he has no edema, good strong regular pulses, no signs of cardiac disease. On palpation there's no heaves, lumps, bumps, crepitus, that sort of thing. On auscultation I can hear normal first and second heart sounds, no added sounds. At this point, Stephen, you're a low acuity patient. But if you were to have a myocardial infarct, anything suggesting that, you start looking cool, pale, sweaty, or anything on your ECG had any changes, then we would call you a high acuity patient and you become status 1 until proven otherwise. Any abnormal vital signs, then we would need to investigate further. Of course, early on I would need to obtain a full set of vitals, as a baseline and regularly compare against this. So we need blood pressures, heart rates, respiration rates, temperature, O2 sats, a 3 lead ECG, a 12 lead ECG, blood glucose, that sort of thing. Okay, so looking at the patient, when you first look at them, looking for signs of shock, that cool, pale, sweaty, shaky, any tremors, that sort of thing, feeling nauseous, that could be indicative that he's compensating shock. Okay, important to note that diabetic patients and older patients, they don't always have the pain associated with the other symptoms because their nerve endings are damaged. Stephen is not diabetic or old, and he didn't imply that he had any pain. Okay, would need to assess his GCS, the Glasgow Coma scale, and any GCS under 9, then we would call him status 1. Stephen at the moment is GCS of 15. He obeys commands, he knows where he is, he's not confused, totally orientated. Okay, we'd also need to ask more questions if we're doing a cardiac exam to find out what's happened. So we need a medical history, need to find out if he's had any coughs or colds, coughing up any sputum, any recent falls, what's his bowels or urine like, any blood, any pain, is he allergic to anything, what medicines is he on, has there been any changes to his medicines, is he compliant with his medicines, is he taking it, does he have any nausea or headache or anything else. You can also look into family history and lots of other things as well. Okay, that will be all for today, so thank you, Stephen.
Thanks very much, Julia.
Okay, bye.